We're going to crack on now. We're delighted to have with us Dr. Joan Hester, who I'm reliably informed, whether she wants me to tell you this or not, I don't know, but she's worked in the NHS for over 40 years, so she's got a huge amount of experience. She's currently a consultant in pain medicine at King's College Hospital, but prior to that, and importantly, she was a consultant down in Eastbourne, where she co-founded the St Wilfrid's Hospice. There's absolutely no doubt from her CV that Joan is right in the front line. She's a clinician teaching patients with many types of pain, and I'm sure we're all looking forward to hearing from her, and I ask you to welcome her to the podium.
Thank you very much for that kind introduction. Can you hear me all right? My voice isn't quite as loud as the previous speaker. You don't want to hear my American accent, that's not good. Neuropathic pain and transverse myelitis. It could have been transverse myelitis and neuropathic pain. Either way. The last group I spoke to on neuropathic pain was the Diabetic Foot Association. And whatever neuropathic pain it is, there are definite overlaps. I work, as Roger's kindly said, at King's College Hospital, which is a major neuroscience centre, and I've worked there since 2004. And I have to say, I haven't been referred a patient with transverse myelitis. I don't know what that says to you, either that it's a very rare condition, or that patients aren't referred to pain management specialists. I'm referred many, many other patients and see a number of spinal cord injuries. So my experience is largely from MS and spinal cord injuries. But I think this will apply very well to your condition also. So, pain. What is pain? Now this definition of pain is an old one, really. It came from the International Association for the Study of Pain, which is centred in Seattle, where a wonderful man called Dr. Joan, an anaesthetist, or anesthesiologist as they're called in the States, in the 1950s wrote a book on pain and the management of pain. And it was then that the whole thinking about the treatment of pain changed, and the neuroscience of pain started to develop. And I have to tell you a little bit more about the neuroscience of pain in my talk, because I think the understanding, as Dr. Kerr was saying, the understanding of the myelitis, the understanding of pain transmission helps you to understand why the pain persists even when healing has occurred. The science has leapt ahead, and the science, I'm afraid, is a long way ahead of the treatments that are available for pain. But I hope my talk will give you some new insights. So pain is undoubtedly unpleasant. It's necessary though. Do you know if there are certain families that are born unable to sense pain? It's a very, very rare state, but there are some families. There was a recent Horizon programme on BBC on a Monday evening on pain, and they showed an Italian family who were born unable to sense pain. And of course what happens is that you may die early because you don't know you've got a life-threatening condition, such as appendicitis, and also you will damage your joints. The child in that family was quite happy to leap off a tall brick wall, 10 feet or so, and just land on her legs because she felt nothing. But repeated trauma of that sort will damage your joints, and in the end you'll be completely disabled through damaged joints. In diabetes this also happens. It's called a Charcot joint because the diabetes affects the nerves. So if you have weakness and lack of pain, in fact the weakness in a way protects you from getting those secondary consequences. Now, pain is always a sensory and emotional experience. You can't divorce the emotions from pain. As I will explain, the pain sensation is coming up through the spinal cord to your brain. It interlinks with many, many, many areas of your brain: memory, appetite, sleep, mood, anxiety, memory, what happened previously when you had a painful experience. And all these things from the brain then feed back to the spinal cord like an enormously complicated computer, which I'll explain a little bit more to you. So pain is misery, the worst of all evils, as Milton said in Paradise Lost. And this, if you're interested in pain as a sort of philosophical subject, I don't think that's very philosophical. The two saints are replacing the leg, which interestingly looks much more dusky and black than the one that's being offered. And is the poor patient having any analgesia for his amputation? There was none in those days, there was none. They used the power of prayer, they used cold. It's only recently that we've had things, apart from opium, which has been around for a long time. But it's a very good read, and I'd like to say it was written by a pain specialist. It wasn't. It was written by a chemical pathologist who in his retirement wanted to write it. It's very, very good. So when a pain specialist thinks about pain, we classify it in this way. Now, I don't know if you understand the term nociceptive, but that means pain that comes from any part of your body that's not a nerve. So it's muscle, it's joint, it's bone, it's ligament, anything that's not a nerve. Inflammation, which occurs in the acute state of transverse myelitis, as it occurs in lots of other conditions, inflammatory pain means that at that site of inflammation, your body is putting out what we call an inflammatory soup. Chemicals, more and more have been discovered. There used to be 2, radikinins and prostaglandins. Now we know there are 30, 40, 50. Every time I go to a lecture, there are more, and we know a lot more about them. And it's these that are activating the pain sensing mechanisms. Now, if you have an injury, a simple injury, I ask medical students, and I'm teaching them, if any of them have had a recent injury, usually it's something like an inflamed tendon in the foot because they're going running and keeping fit. And you say, okay, when was it? 10 days ago, they're walking fairly normally. And I say, let's test your foot with a pin and see what you can feel. And you find near that inflamed tendon, there will be an area where they feel the pinprick much more acutely than normal. That's something we call hyperalgesia. So algesia is pain, hyper is more. There's another thing that we talk about called allodynia, A-L-L-O-D-Y-N-I-A. That's perceiving something that's normally a touch as being painful. Now that will happen when you've got neuropathic pain. It's more likely to happen above the level of the damage in your spinal cord. But that is a horrible thing because every bedclothes that's on any article of clothing will feel actually painful. People with strokes get what's called cold allodynia. If they go into cold water, they feel it as being acutely painful. One of the rehabilitations perhaps is swimming. And I had a patient who liked to swim in the sea. And the pebbles, the stones were, I find them pretty uncomfortable, but acutely painful. And the cold water, it's shocking at the best of times, but it gave more and more pain. So cold and hot and other kinds of painful experiences are all transmitted in different nerves, so it gets more and more complicated. Neuropathic pain is damage to a nerve anywhere along its course. So it could be a nerve in the hand, a little nerve in the finger, it could be a nerve anywhere in the body, going right up the nerve trunks to the spinal cord itself. So anywhere along the nervous system. Visceral pain is pain that comes from any of your internal organs. You think of the bladder and you think of the bowel, but you've also got the liver and the pancreas and the heart. And all these organs, you don't normally know that they're there. You're not there thinking about your liver. Well, I hope you're not. But when something happens to it, or when it's kind of persistent inflammatory process, it can become painful. Pain is rarely all psychological. I think there are some people with very severe depression. Pain can be a presentation of depression, but their pain is extremely rarely psychological in origin. But mood changes in response to pain. And then most pains are mixed pain and are a mixture of all these things. So this is rather a busy slide, but what I want you to focus on is, one, the fact that in transverse myelitis you can also still get other kinds of pain. You can get muscular pain, and because you're likely to be overusing one part of your body in response to the weakness in the other part, the good part might start to be pain from overuse, because you might be stressing one leg, one lot of joints more than the other side. And also the upper part of your body, if you've got weak legs, will be using sticks, crutches, be supporting you more, will be more tense in some respects, and can give you more pain. So pain is not all neuropathic. Visceral pain I've mentioned briefly. And the neuropathic pain can again be at three levels. It can be at the level of the myelitis, it can be above it and below it. And all three will be slightly subtly different. So the sensitivity may occur above it. At the level, you'll get the inflammatory process. You can get areas of what we call ischemia, areas where the spinal cord isn't getting its blood supply. Have you ever thought about how big the spinal cord is? It's extremely small. A male spinal cord is about the size of a man's index finger, which will be bigger than mine. And a lady's spinal cord will be the size of a man's little finger. It's much smaller in women. So think about that. Such a small diameter carries so much important information. It's incredible. Syringomyelia, I don't know if you know what that is, but sometimes in response to any injury to the spinal cord, a cavity forms, which is called a syrinx, in the middle of the spinal cord. And this, of course, can add to the problem, because particularly the pain fibres, which cross over from one side of the body to the other, can be affected by that. That shows on an MRI scan. And then below the level of myelitis, the types of pain that Dr. Kerr described so well this morning, including the muscle spasm. And if ever you get an infection in any part of your body, even if it's in an area which is numb, that winds the pain up. And this happens after spinal cord injury, where there's complete loss of function and feeling below the level of the lesion. That an infection of the big toe will wind the pain up, even though the circuits have been completely disrupted. Now, that's something doctors find very hard to get their brains around. So I'm sure you're aware. You can't have pain. Now, this is taken off the internet, and what I want you to see here is the spinal cord actually ends at about L1, L2 in the upper part of the lumbar spine. The cerebrospinal fluid actually ends in about here at the top of the sacrum, what we call S2, and then you have a little the filum terminale which goes down further. And Dr. Kerr has really explained the anatomy very clearly to you. You have to remember that an average doctor, talk against my profession here, will have forgotten some of these things. If I lecture a group of GPs, they will actually have forgotten where the spinal cord ends and where the CSF ends. And the average fourth-year medical student doesn't know it either. So you have to remind people. It gets into a blur, and medical students don't do a lot of anatomy these days. So be kind and remember that. They know a lot of things, but that is not one of them. So I don't have to tell you that pain that comes from the spinal cord is severe. It's the most severe type of pain that I will see in my clinic. Anything, any injury, anything that affects the spinal cord is very severe. And it's very severe because it's what we call central, and it's affecting these pain pathways. If you damage one nerve on the periphery, it's one little bit, but the central, because it's such a complex area, so much information is going to be more severe. I don't have to really go through the rest. All pain, but particularly central neuropathic pain, affects activities, it disrupts sleep, changes life, it disrupts social interactions, it alters mood, work, relationships with other people, finances, and it's difficult to treat and manage. So, why is it so painful? I've told you about the complexity of the spinal cord, and there are many, many chemical neurotransmitters that are released in response to the signals. So the signals are coming into the spinal cord and then they synapse, and every time they synapse, the signal loops from one little nerve to another little nerve across a gap. The gap is called a synapse, and these chemical neurotransmitters are released and they carry the message forward. And the amounts of these neurotransmitters alters when you have damage. So after the injury, the whole system becomes what we call wound up and sensitized, and the signals that go on from the area of damage to your brain become more sensitive, more reactive. They're sending more electricity up to the brain. The whole thing is what we call wound up or sensitized. You might have heard those expressions. And then the brain responds by sending signals back down to the spinal cord, and those signals also can alter. So I describe it to my patients like your spinal cord is a very, very complex computer, and this injury is like having a virus in your PC. But if you spread the brain and the spinal cord, neurological system of the Isle of Wight, I'm hoping Dr. Kerr doesn't know much about the Isle of Wight, it would cover, you need computers covering the whole of the area of the Isle of Wight to reproduce the brain and the spinal cord. It's that complex. So, very clever man in 1664, Descartes, without knowing very much about anatomy, because if you think of when they started dissecting bodies, Leonardo da Vinci did a lot of anatomy actually, but it's against religion to actually look at bodies. But he surmised this, that if you put your toe in the fire, it can send a signal to the brain. Amazing, really. And then science indicated that he was right, but it was a slightly more complex story, of course. This is a picture of what happens with injury. You've got a needle going through the skin here. And all these, sorry, that one's probably the needle, the other one's probably a hair. And these little dots are the inflammatory, what we call the inflammatory mediators coming out. So many, many, many of them. Prostaglandins, neurokinases, interleukins, something called nerve growth factor, which I think you mentioned. Nerve growth factor is very important for pain transmission. And when babies are born, their pain sensing pathways are very immature, and they grow over the first 2 years of life. And they grow dependent on nerve growth factor for development of your pain sensing mechanism. So if babies are isolated and they have no external stimulus, the pain sensing mechanism won't develop. Equally, there's research going on into premature babies who have a lot of interference and a lot of stimulation when they're in incubators, and finding that in later life they might be more sensitive to pain. These little nerve endings are what we call nociceptors. These are C fibers and they're unmyelinated. So the most of pain coming into the spinal cord is in unmyelinated nerves, and they occur all over your body. They go up, they join together, it's like the branches of a tree, and they're coming together as they go further up, and in some circumstances they cross over, so that the signals get crossed. There's a little bit of light, this signal going up the nerve. And how does the nerve do it? It's all to do with sodium ions. And sodium, potassium, sodium, and the interchange from the inside of the nerve to the outside sends the electrical signal across up the nerve. And what do we know now is that genetically people are born with different types of sodium channels. So there's about I don't know, about 13 of these worked out at the moment. And there are some sodium channels specific for pain, not for anything else. And if you happen to miss a protein of one of your chromosomes, then your pain transmission can be abnormal. So this is, how research is informing us. And just a little bit more complicated than Dr. Kerr says with pain, the important parts of the spinal cord for pain are the dorsal horn here, where my little arrow is. Fast pain crosses over to the other side, to the spinothalamic tract, and goes up on the opposite side of the body. That's what alerts your brain that something's painful lower down. So that tract will be disrupted. And the dorsal horn is where the brain sends signals back down to. That's a synapse, very nice picture of a synapse. And the little blobs are the chemicals that are released across the synapse into receptors on the other side. And they will alter when you've got nerve damage. The pain centres in the brain are many. It was thought at one time you had a pain centre for the brain, which was something called the thalamus at the base of the brain. And my little arrow is not very much it's supposed to be. But you can see the red blobs at the base of the brain. These are areas of processing, and then you see the arrows going off to different parts of the brain. We used to think there was only one or two parts of the brain that were responsible for perception of pain. Now we know there are very many. The sensory cortex is one of them, but there are other areas, as shown where these little red lines join up. And the deep parts of the brain, the bits at the bottom, the limbic system, very primitive part of the brain. Even snails have one cell that goes to the limbic system. These are also the reward areas and where different drugs work. The whole thing is very, very complex. But the brain feeds back to these centres in the midbrain, the blobs at the bottom there. And it's known now that it's like a switch, that the brain can switch one way or the other, those centres at the bottom of the brain. And the signals that go back down to the damaged area of the spinal cord can alter. The brain can wind them up, or it can wind them down. And the winding up and winding down mechanisms involve different chemicals. See how complex it all is. So this is functional MRI. If you have an ordinary MRI scanner, you don't get these pictures. These are research scanners. They're very powerful. They're what we call 3 Tesla, which are much more powerful than it's a magnetic field than an ordinary MRI scan. And you can see an area of the brain lighting up there, red for pain, different areas. They've even studied people making love in an MRI scanner. And surprise, surprise, the areas of the brain that light up in the male are different. And they also, as you like this little story, did the experiment when the participants were wearing socks and when they were not wearing socks.
Why always keep our socks up?
I mustn't digress, but getting back to pain, so the different areas of the brain that light up. And if people have widespread body pain, more and more areas of the brain light up in response to that pain. And the lighting up means that the areas have a bigger blood flow. Right, so the brain is important, and this is a sort of, I wish I had a pointer. Let's try and see if this does work. Yes, it does work. So, these are the signals coming in. This is the spinal cord here, and those feedback loops in what we call the dorsal horn. And every time they feed back, different chemicals are released. One of them is GABA, and then opiates, morphine-like substances, act here as well. They really act everywhere. The signals are going up to the brain, the limbic system, and then to higher centres, mood and state of mind. The whole thing's feeding back on those centres in the brain, different areas, and again, you can inhibit the pain, and you can wind it up. And we now know that different drugs act in different places. So for instance, gabapentin and pregabalin act here because they're altering the chemicals that cross that synapse and making fewer chemicals cross the synapse. Opioids act everywhere. They act in the spinal cord and they act in the brain. Things like antidepressants, I'm sure you've all heard about amitriptyline, they act on these pathways and inhibit what we call the reuptake of noradrenaline. So in fact, they're enhancing these inhibitory pathways. And other antidepressants do that as well. This pathway that winds the pain up is actually blocked by a drug called Ondansetron, which is used for nausea and vomiting. And we don't yet have a drug that will be useful on this pathway, but people are working on it. Things like ketamine work in the cells in the dorsal horn of the spinal cord, and they're responsible for this phenomenon called wind-up, or the chemical that ketamine blocks. Sorry, I don't want to get too complicated, but if you want to ask me any questions afterwards on the science, I'll be happy to answer them. So, you all want to know about pain management, but I'd still say understanding the mechanism is really, really important. And it's important to have all the types of pain that you are experiencing assessed properly by the person who's looking at you, because the treatment of different kinds of pain is subtly different. And you can't take pain in isolation from mood, function, and exercise, as Dr. Kerr was saying, will also help pain, because exercise will help to blot out some of those mechanisms that get wound up. You've got to think about the adverse effect of drugs, you've got to think about rehabilitation, and it's very important with pain. People come to me time and time again and they want an answer. You can see from what I've just said, it's such a complex thing. How can there be one answer? For every individual, it's going to be different. But it's so important for that individual to set little achievable goals. If you achieve a goal in reducing the pain, even by a little bit, then you can go on to the next one. If you try to get rid of it all, and doctors love to close, you know, they love closure. We're all asked to get rid of patients out of clinics, which we can't do with a chronic problem. You have to work on it over a period of time. And the decreasing spasms is also important. Now, list of drugs here. If you can see a list of drugs, as long as this, for any type of condition, you know that nothing's working very well. Okay, so I'll just mention a few. If I see a person with any injury or pain coming from the spinal cord, my natural starting drugs will be pregabalin and baclofen, a mixture of the two. Now, why pregabalin, not gabapentin? Because there is some evidence that it may work a little better on central pain, but either will be quite acceptable. If you get to high levels of gabapentin and you give more, you're not going to get very much more effect. It's all right in the low doses, but when you get to the high doses, it's not doing very much more. In Australia, where they particularly studied spinal cord injury pain, they do a lot of intravenous lidocaine, giving people injections of lidocaine repeatedly. We don't tend to do this in this country. It has a limited effect, has to be given in hospital, because lidocaine or lidocaine given intravenously can cause cardiac arrhythmias and problems, so it has to be done carefully. And in this country, it's not a sort of approved in inverted commas treatment. Our second line would be amitriptyline or nortriptyline, is very similar. As you know, used for depression, act by inhibiting these signals in the spinal cord. And duloxetine is a newer antidepressant that's been licensed for types of neuropathic pain. Ketamine, I can come back to. Ketamine is a street drug. It has unpleasant side effects, has to be used very carefully and in low doses, and you may or may not be able to get it. It has a limited beneficial effect, I would say. There are other anti-epileptic drugs. Gabapentin is an anti-epileptic drug. And just a quick word about opioids. An opiate is something derived from the opium poppy. An opioid is anything that acts in the same way, so it acts on what we call a new receptor, but it may be semi-synthetic. Now, just bear in mind that morphine also affects the immune system. Morphine suppresses the immune system. Now, the significance, it's been known for a long time, but the significance has never been really established. So I can't tell you very much more, except that it does. Some other opioids do not affect the immune system, so fentanyl doesn't, and buprenorphine doesn't, and nor does tramadol. Oxycodone does to a degree. All these drugs, given long-term, also suppress your hormones through the pituitary. And over a period of time, and particularly testosterone in men and estradiol, which affects the ovaries in women, are suppressed more by morphine than some of the others, but can be suppressed by all of them. So bear that in mind. Large doses of opioids over a long period of time need to be very carefully managed. That's what I would say. Tapentadol is a new analgesic that will be licensed in the UK in May. It's already available in the United States. And I don't know, we don't know, just by all the careful trialing, how it will pan out. But it acts in the same way as opioids, subtly differently, but it acts on the same receptors in the brain, but it also acts on the noradrenaline reuptake pathways, so it has a dual effect. And it's been shown in the trials to be good for neuropathic pain with fewer side effects. And it doesn't, as far as we know, affect the immune system. So it's watch this space with Tapentadol. Clonidine, as you know, is used, I can come back to that. And cannabis, if you smoke cannabis, it has 62 different ingredients, cannabinoids, and you don't know which you're actually smoking. It will vary, like a grape, according to where it was grown, what the growing conditions were like, etc., etc. The medically produced cannabis, there's two things. There's a tablet, and it's just gone out of my head, it will come back to me, which was originally licensed when I was in vomiting, and there's a spray called Sativex. Now, it isn't actually very good for pain. It's good for spasms, but not for pain. So I think at the moment I couldn't recommend the medical version of cannabis for pain. So other therapies, I know, yeah, a couple of minutes.
Yeah, thanks.
Yeah, is that all right?
Yeah.
I won't go into these in detail, but all these are very important to combine with your drugs. Imagery is something that psychologists are beginning to use more and more, and something called mindfulness. And there are some computer packages being developed for pain, so that you can use at home. So if it's not available to you by a psychologist, and I realise it's very difficult sometimes, these things will work on your top-down pathways. And then other things, just to touch on at the end, I can come back to spinal cord stimulation. Deep brain stimulation hasn't really been shown to be effective for pain. It's a new technique of motor cortex stimulation, which is in its early stages of research, but has been shown to have some effects on pain. And the intrathecal drug delivery I can comment on. So let me just finish by showing you a spinal cord stimulator, an intrathecal drug delivery system. This is a reservoir that is put under the skin. The catheter or the tube goes up into the fluid bathing the spinal cord. And this has been used for spinal cord injury pain. I've no personal experience for transverse myelitis. You have to remember that it is putting something into the spinal canal where the area of injury is. Whether that's a good thing or not can be debatable. The drugs that are put into it will be morphine, clonidine and or baclofen, and or local anesthetic. And it's controlled by a computer with a little device that's held over the skin and communicates with it. And it's possible to have a patient-activated device there, which a patient can press to give another dose of the drugs. but it can only be put in really under the care of a pain physician or a rehabilitation specialist. So I can answer more questions about that, but just to conclude, we know that pain is very difficult to control. The multidisciplinary team, including a pain specialist, I would say, would be very important. Understanding the pain mechanisms, if you forget everything else, that's really important. The science is advancing and giving us hope. And I think there is hope for the future, as Dr. Kerr also has expounded to you. So we're really brilliant. Thank you very much.